information. It was recently published in Circulation Research, the multifunctional role. And at the outset, because I only have 20 minutes, I just want to acknowledge Pam, Betty, Eddie, who we've been working together for almost 20 years, Justin, Kevin, Silvio, Jamie, Brittany Butts, who now has a faculty position at Emory, and my dear friend Jim Colon, sitting over there. I would never be able to go vertical mechanistically without him. Chymase as a therapeutic target. It's a 30 kilodalton protein. Now, it's the predominant Ang2 forming mechanism in the heart. It's more catalytically efficient than ACE. Very well proven. That's also kind of a double-edged sword because it's prevented chymase from going to the bedside because everybody thinks if you have an ARB, you can block all the Ang2 that's formed. So that is the big, big problem. Next slide. Oh, me. But the multifunction, it activates TGF-beta, a huge activator of MMPs, especially MMP9. Degrades fibronectin and laminin. It's been shown in vitro that when that happens, it causes cellular apoptosis. It activates IL-6, IL-1 beta, IL-18, activates stem cell factor, neutrophil, and mast cell recruitment. And of course, we talked about Ang2. It activates kallikrein to form bradykinin, converts pre-pro-endothelin-1 to endothelin-2, and degrades IGF-1. So all of these things, and you know, this is not new for any protease. Proteases chew up proteins. There's more to chymase than angiotensin II. In this, there are about 300 references in this paper, and what we really tried to do is show all of the human conditions in which chymase is upregulated. Preeclampsia, keloids of the skin, atopic dermatitis. There was actually a trial of a chymase inhibitor in atopic dermatitis. But I'm going to concentrate on a few things here. Highly upregulated in the diabetic heart and diabetic vasculature and the diabetic kidney. In vitro, chymase increases, glucose increases chymase production. Ken Baker's work in both fibroblasts and neonatal rats. Ischemia, neonatal rat cells, myocytes. Ischemia reperfusion. This is really interesting. The vulnerable atherosclerotic plaque, post-MI remodeling, for which now there is a clinical phase 2 trial by the compound that Bayer has in patients post-MI with an ejection fraction of less than 50%, followed baseline by MRI and 6 months later, and volume overload. Now, this is an old slide from Walter Frischli. If you give Ang1 to an isolated internal mammary artery, you get a contraction. If you give losartan, it's blocked, the contraction. Interestingly, if you give cilazaprolab, which is an ACE inhibitor, it's not blocked. You still have a contraction. If you give chymostatin, a chymase inhibitor, it's blocked. Here again, if you give the Ang1 chymase-specific substrate, you have a contraction, and with chymostatin, it's blocked. Now, why? These arrows point to mast cells in an infarct-related artery, okay? And these are all here in the adventitia and surrounding the smooth muscle cells. They are segments with plaque rupture. There is a larger proportion of mast cells contained versus segments with non-ruptured plaque. So mast cells are really the chameleons of host defense. They change their contents depending upon the milieu, the organ. And if you look at a human heart and look at the from an autopsy, the non-infarcted coronary artery segment and the infarcted, the chymase contribution or the chymase content of mast cells is like 8-fold higher. So think about it. What that might mean. And also some great work related to looking at the shoulder region of the atherosclerotic plaque, and where you know it is vulnerable for rupture. And think about the things I told you that Chymase does. Activates MMPs, clearly. Breaks down fibronectin, breaks down laminin. So Chymase in human studies has been associated in the shoulder region of the atherosclerotic plaque. And these arrows, if you could turn the lights down for a second, please, Darian. You can see these arrows pointing to all the mast cells here in the adventitia of this artery, right around there. Next slide. Oh, me. So the identification of Chymase in the human infarct artery in the shoulder region, vulnerable plaque, and a prominent vasoconstrictor response in the coronary artery. So again, it raises the question that, if a person has a non-ST-MI or an MI, the chances of them having another infarct are in a vessel that really isn't severely stenotic. You could bring the lights up again, please. So you wonder whether a Chymase inhibitor for a short period of time, 6 months, might stabilize a plaque. And remember, I'm showing you all human data. Chymase has also been associated in thoracic aneurysms. And again, think about what causes an aneurysm. MMP activation. Chymase activates MMPs. This is a beautiful pig study demonstrating that at the time of ischemia reperfusion, at the time of the occlusion of the artery, intravenous administration of a Chymase inhibitor results in a marked decrease in infarct size. Serum troponin is down, and MMP9 activity is down. This is an interesting paper that we published in the JCI now about 8 years ago, where one thing I failed to mention, and again in 20 minutes it's really hard. Chymase is a serine protease. There's only one alpha isoform in the human. In the rat, there are 10, 5 that have been characterized. So it's really hard to do any preclinical studies in a mouse or a rodent. The hamster, though, has one alpha chymase. And this work that we did with Hide Urata, where he did a total occlusion of an LAD, okay? Gave a Chymase inhibitor versus an ACE inhibitor versus an ACE inhibitor plus a Chymase inhibitor, okay? Starting right at the occlusion and for 1 month. And what I'd like to do is, that's ejection fraction, that's the combined therapy, that's fractional shortening, that's the combined therapy, that is, see, I can't even see it here. Cardiomyocyte diameter, that's the combined therapy. This is LV interstitial fibrosis, that's the combined therapy versus ACE inhibitor alone versus Chymase inhibitor alone. That's the combined therapy, infarct size, and left ventricular end diastolic diameter, and mortality. Sham, Chymase inhibitor, MI plus Chymase inhibitor, MI. So you can see that the Chymase inhibitor, right up here, the combination therapy was quite effective. Now, why might that be? So the other thing we did in this study was we did cardiac microdialysis, and we gave an ACE inhibitor. And then during or after the ACE inhibitor, we measured Chymase activity through the microdialysis probe. And what was interesting is, after giving captopril, Chymase activity went way up. And what was interesting was, ACE inhibitors are more catalytically efficient in cleaving kallikrein to bradykinin. and inhibiting that as a kinase inhibitor. So when you give an ACE inhibitor, your bradykinin levels go way up. And in the setting of an infarct or a bee sting, if you give a kinase inhibitor, you're going to get more edema. Well, here we also noted that mast cell protease 4, which is in red, is basically there with the bradykinin on mast cells. So actually, I think what's happening is that the ACE inhibitor is causing mast cell degranulation and a reflex increase in chymase activity. There are papers out there showing increased chymase activity in the human heart. Maybe early chymase inhibition coupled with later ACE inhibition may provide the best outcome, because you know giving an ACE inhibitor early in the Consensus 2 trial had an adverse effect. I told you about the study that's going on with Bayer, and I don't know, maybe chymase inhibitor might be an important thing to add to a cardioplegic solution to prevent ischemia reperfusion injury. Now I really need all the lights down. Darian, thank you. So the dog, as I told you, has one alpha chymase. And we did a study basically occluding the LAD for an hour and then reperfusing for 2 hours, and then the dog was sacrificed. This is Desmin in green. Blue is the nuclear DAPI. And what you see are these minimal dots here of red, which are chymase. And this is what happens after ischemia reperfusion. Look at all the chymase inside the cardiomyocyte. It could be due to mast cell degranulation. However, we have shown that other cells besides the mast cell can produce chymase, especially endothelial cells and fibroblasts. So the chymase in the cardiomyocyte now raises a very important question regarding could chymase be activating MMPs inside the cardiomyocyte? Could chymase be forming Ang2 signaling cascades? Because when you think of chronically with an ACE inhibitor or an ARB, it works on the cell surface. Chymase gets into the cell and may actually prevent or affect intracellular Ang2 formation. Well, this is what we've been studying for quite a while at UAB, and that's mitral regurgitation. And the reason why I got into chymase was because about 20 years ago, we were looking at ACE inhibitors versus ARBs in the treatment of MR in the dog, and they didn't have any effect. And lo and behold, we found chymase upregulated, and then started thinking about all the other things beside Ang2 formation that chymase does. And now what we're doing at the time of surgery is we're getting a biopsy here, a biopsy here, and a biopsy from the right atrium. But this is what happens to the left atrium compared to normal in an MR patient here at atrial end systole and atrial end diastole, and look at the atrial appendage. In the presence of, look at that ejection fraction, because the left ventricle is ejecting into the low pressure left atrium. Next slide. Me. This is a 3D reconstruction showing how much the left atrium increases at both end systole and end diastole compared to an age-matched normal. This is what we found. The chymase activity in the left atrium is much higher than the right atrium or the left ventricle. Chymase activity is related to TGF-beta. Chymase activity is negative related to left atrial ejection fraction and left atrial volume increase. Left atrial emptying fraction, or ejection fraction, is also negative related to TGF-beta and positively to the increase in volume. So you can see we've made a connection between function, TGF-beta, and chymase in the human left atrium. And this is a normal left atrial cell from a patient provided by Dr. Lutovsky. from an autopsy, and you see there's not much red. Well, these are mast cells here in the interstitium. And you see that the desmin is really broken down. There's a lot of space, and there's a lot of blue dots in there, and I'll show you what that is in a minute. But notice the chymase here in the interstitium, and extensive fibrosis in this patient with mitral regurgitation. All of them, no matter what the size of the atrium, there was extensive fibrosis. And this is the Guillaume stain showing a mast cell degranulating. This is a myocardium, and this is all fibrosis here. But you see the association between the chymase, the fibrosis in the interstitium, and the mast cell degranulation, and the granules out in the interstitium. This is an orderly pattern, again, of a left atrium from Dr. Litovsky with desmin in green, DAPI. And this is what happens. Desmin degradation with the stretch on the atrium. It's there in the right atrium, and it's there in the left ventricle of the same patients with mitral regurgitation. And the reason why I have the lights down is because look at all these red dots inside the myocardium. We did transmission microscopy, immunogold, electron microscopy, and there are the chymase dots. So this is a sort of a blow-up of the IHC. This is at 40,000 X. So we're looking at that area right there. And there are the chymase dots. The chymase is also in the mitochondria, here in the myofibrils, over here in the outside the myofibrils. This is an area of myofibril breakdown. And the other thing that we did was, and again, I have to credit everybody who I said ahead of time who works with us. This is in situ chymotryptic activity. And this shows the blue staining is a mast cell. And anything chymotryptic is going to show up as blue. And you see the bleeding into the myocyte. When this tissue is pre-incubated with the chymase-specific inhibitor, the mast cell, you can see, is very much decreased. You can't knock it all out because look at it. It's full of chymotryptic enzymes. And this is what it looks like when you look at a longitudinal section and you see all of these chymotryptic, evidence of chymotryptic activity along the longitudinal section of the myocyte, and pretty much gone with incubation with the inhibitor. The other thing that we see is a marked breakdown in myofibrils in both the right atrium, the left atrium, especially the left ventricle. We've published the left ventricle before. But there's a proliferation of myocytes, there's glycogen accumulation, but most importantly, this is what I want to point out. All of this myofibrillar degeneration. So with the help of Jim and Pam and Betty and everyone, we gave chymase to a cell, an isolated cardiomyocyte, and I think you can see here in red all of the red dots of chymase entering the cell. And we've done this in HL1 cells published in JMCC, adult rat cardiofibroblasts, showing uptake of chymase that is prevented by a dynamin inhibitor, which is dingo. So you see the difference here. But what's important, and this is, we've sent this out for publication, is that when you look at myosin here, and you look at chymase, you see a breakdown of the myosin completely. See this big thing here? It's mostly myosin. But when you prevent the uptake of chymase into the cell, you have at least an attenuation of the myosin breakdown. And finally, we have this in the rat. It's in review. We're about to send this out in the patients. But this is in situ hybridization demonstrating the source of chymase in fibroblasts. This is a blood vessel, endothelial cells. Here's another small vessel. That's a mast cell. And that's a mast cell. There are other examples of the mast cells really, really lighten up. And this is the sense control. So in the rat and in human, it looks like that the major source of chymase is mast cells, but also other cells, including endothelial cells. And this is what Hassan Hussein demonstrated in the human heart about 20 years ago. See, now this is can everybody see this green and that's red? There's not really much red there. This is a dog, a normal dog, and you see the Desmin here in nice regular alignment, and with chronic mitral regurgitation, the Desmin is broken down, and can you see the red dots there?
Yeah.
Honestly, it's really impressive on the microscope and looking at it close. But these red dots are inside the cardiomyocyte. So we gave these dogs a chymase inhibitor for 4 months. And what happened was, this is what the Desmin looked like without treatment. Red is myosin, and here it is merged. But with the chymase inhibitor, these are two different dogs. The chymase and myosin, the Desmin and myosin was preserved. So I can't say what's breaking down myosin or Desmin, but chymase is in there. And right now, not too sure whether it's interacting with calpain or doing something by itself, but it's in there. And if you think about this, if it's in there, it is untouched by an ACE inhibitor or an ARB because they work on the cell surface. So, and the other thing was, interestingly, the isolated cardiomyocyte function in these animals was depressed with MR and normalized with a chymase inhibitor, as well as the systolic function. So, summary for the role of chymase to attack what people are calling the gap in efficacy or the residual risk in combined ACE inhibitor ARB. I think we've seen what the neutral endopeptidase has done, adding to an ARB. So I think, moving away from Ang2 and norepinephrine, and we need blockade of those neurohormones, other targets, and especially proteases like chymase. That also, what I need to tell you is that there's increased expression in African Americans, aging rats, female versus males, all been published. It's in the review, and in oophorectomized rats. So race, age, and gender could add to the residual risk and the benefits of chymase. It's multifunctional protease actions. The question is, do you want it there do you want it blocked all the time, or do you want to understand the pathophysiology of what you're talking about? In the infarct-related setting, maybe for 2 weeks. In the atherosclerotic plaque, certainly maybe for a period of time after a myocardial, a non-transmural myocardial infarction. I don't know, you need to think about this blockade, because we've been burnt in blocking inflammation chronically in patients. And its intracellular presence and actions, even in the presence of an ACE inhibitor or an AT1 receptor blocker. And Doug, this is what I was referring to. So we measured pericardial fluid chymase after surgery from a drain in patients. And what we found was, when compared to, I think, 15 IL-6, IL-1, troponin, myeloperoxidase, all of these proteins, chymase was the only independent predictor of post-cardiac surgery with length of hospital stay, both total stay and stay in the ICU. So maybe ischemia reperfusion injury might be a nice place to start with a chymase inhibitor. Thank you.